Thank you very much, Enzo. I've been asked to talk a little bit about how we predict keratoconus progression. Well, we're going to look a little differently, and I look at this that the goal of cross-linking should be the prevention of sequela, not just stabilization after loss of function. And I know this will be heresy to say, especially in Enzo's meeting, but I view DALK as a diagnostic failure. The reason we do DALK is because we're intervening way too late in these cases. This is really our current approach to keratoconus. In the US, we call this an idiot light. It goes on in your car when things have gotten to the point that damage is being done already. We really need to be able to monitor disease the way we monitor modern cars, and that is by gauging problems before they actually cause damage. This is what many people use, and this is all in the published literature now, the different parameters people utilize to determine progression of keratoconus. So if you look down this list, first of all, none of them have really been well validated, and I'll be the first to admit what I'm going to propose has not been validated either. But if you look at all these, except for one, which is pachymetry, they're all anterior surface parameters. That means we're determining progression of disease after patients have already lost visual acuity, after they already have changes on the anterior surface. It's 2.5 years ago, the 4 major national cornea societies came out with this global consensus on ectatic disease, and one of the conclusions is that we don't have a good way to characterize disease, classify disease, stage disease, nor determine when and if progression occurs. What we really need is we need a classification and a staging system that recognizes all the anatomical layers, not just the anterior surface. The anterior surface is a late change. We need to have something that recognizes the anterior surface, the posterior surface, and also the corneal thickness. We need to have something that's relatively simple parameters that should be platform independent as long as you can measure all the surfaces, and it should be a way to convey the information in an easy fashion. And the reason for that is, a decade or two ago, all we really had were contact lenses with penetrating keratoplasty. So our therapies were only instituted when we had advanced changes that left with loss of vision. Now we have cross-linking, rings, DALK, PK, and lenses. But the cross-linking is really the big change, because we have now an ability to intervene with a treatment to stabilize or slow progression before loss of vision. And that means identifying disease much, much earlier than we have in the past. Now, many of you are familiar with the Belin Enhanced Ectasia display. And in that display, we have something called an enhanced reference surface. And the enhanced reference surface tries to get a reference surface that simulates a normal cornea. And we do that by eliminating a 3 millimeter zone on the center, centered on the thinnest point, and then computing a best fit surface on the rest of the data. That works because that exclusion area shown in red debulks most of the ectatic region. Well, instead of using it for the Belin display, instead of excluding that, the reason that works is because, again, it represents the bulk of the ectatic region. So to classify or stage disease, let's look at that red zone to help determine or classify disease. So what we've done is we've looked at that 3 millimeter zone, both on the anterior surface and the posterior surface, centered on the thinnest point. Because the posterior cornea, and here's where it's going to sound confusing, but actually is really relatively easy. Because the posterior cornea is a low power minus lens, diopters become somewhat awkward and not very intuitive. Radius of curvature is a much better parameter when we're looking at both the anterior and the posterior corneal surface. And we came out with what we call an ABCD classification. A is for the anterior surface, and that's the anterior radius of curvature centered on the thinnest point, taken from a 3 millimeter zone. B is back or posterior radius of curvature. C is thinnest corneal point, and D is distance visual acuity. That would be best spectacle correct visual acuity. It looks confusing, but actually it's done automatically by the machine. This is currently available on the Penacam, though it's purposely not been patented, so it's available to any company that may want to utilize it. And it's part of the topometric staging system. This is a blow-up of what that looks like, and it gives you 3 different bits of information. Graphically, it shows you each layer, A, B, C, and D, and where it would fall. The actual classification is listed below. In this case, you would see A0. It's a normal anterior surface, so an asymptomatic patient. B4, it's a positive, a very large posterior ectasia. C3, a moderately thin cornea, but D0, normal distance visual acuity. Again, on the old classification, this is not even recognized as disease. This is where we want to be able to identify and intervene. The actual numbers on the left side will give you the radius of curvatures, and that is really the best descriptor of that individual patient's cornea. Let's look at a couple examples. Here is a very normal eye. You can see graphically all the parameters are close to 0, and again, all the classifications are 0. It's a normal eye. Here is a very early ectatic change. You can see it's A1, B0, C0, D1. Again, slight loss of vision because we have some mild anterior changes. Here's more moderately advanced disease, and I think no one will miss this is advanced keratoconus, and you can see we're actually off the scale both on the anterior surface and the posterior surface. But the real goal of the classification wasn't just to classify disease, it was to help us determine when and if true progression occurs. And in order to determine whether it's true progression occurs, we need to know what the noise levels were of these individual parameters. In other words, do we have statistically significant change? So we had to determine the noise levels of these parameters. Now, the A and B parameters were new parameters that we've never looked at before. We also determined that it was important to study noise levels both on a normal population and a keratoconic population. Because in older patients with established disease, the noise levels of those measurements more closely mimic a keratoconic population. But in your very young, very early subclinical disease, the noise levels of those probably more closely mimic the normal population. And we've published this information, and what we have here are both an 80 and 95% one-sided confidence interval, one-sided because we're only interested if the cornea steepens or thins. And what you'll notice is exactly what we would anticipate. The noise levels in red represent the keratoconic. Those are much higher than the noise levels in green, which represent the normal population. We came up with what we call a ABCD keratoconus progression display. It'll allow you to graphically display up to 8 exams over time. It will show you both the 80 and 95% confidence intervals, both in the normal and the keratoconic population. The solid lines represent the 95%, the dashed lines the 80%, green represents the normal population, and red represents the keratoconic population. You can also indicate when and if you've done cross-linking, and those are that hashed black and white lines. Let's look at a couple examples. So this is a 33-year-old patient with 8 years of follow-up. It will retrospectively analyze past data. Here you can see on the first exam to the second exam, things were relatively stable, but notice what happened at the third exam in green. We have highly statistically significant change, both on the anterior surface, the posterior surface, and by the fourth exam, also on corneal thickness. This is a 15-year-old with advanced keratoconus over 7 years follow-up, and again, you can document it here, continued progression of disease. What's important in this patient, if you notice from the initial exam, they were relatively asymptomatic. But by the second exam, even though the patient was relatively asymptomatic, they had highly statistically significant change. That would have been the time to intervene. This is a 15-year-old with early keratoconus and a 21. This is interesting because if you look at the first graph, here we have highly statistically significant change on the anterior surface, while in the contralateral eye, the significant change was on the posterior surface. But again, highly statistically significant change by the second exam. This is a series of cases we've published about a year ago in cornea of documented, tomographically documented unilateral keratoconus in patients without any history of eye rubbing. You can see on the left, this is over a 7-year period, absolutely no change, but notice in the other eye, which had obvious keratoconus, statistically significant change. And I think this is probably the most informative sample of the utilization of this. This is a patient who had asymmetric keratoconus. The other eye was cross-linked because it was more advanced, but both the patient and the surgeon decided we're going to watch your other eye because you basically have excellent visual acuity, you're asymptomatic, and your disease is very, very early. And the patient wanted to spare both the discomfort and the expense of cross-linking. So this patient was followed over a period of about 5 years. I don't know if you can read the numbers, but they originally had between 2015 and 2020 vision. And over a period of 5 years, they've had a slight decrease in vision, and eventually came to the surgeon and said, okay, I've had a 2-line loss of vision. They went down to about 2025, and that's when they decided to get cross-linked on the other eye. But if you look, by the second exam, they had highly statistically significant change both on the anterior surface and the posterior surface. If this was available 5 years ago, the surgeon could have sat down with the patient and explained, though you still have good vision, I can clearly show you that your disease is progressing at a rapid rate. They could have intervened earlier and intervened at a point where they had normal vision, not wait until they've had deep decreased vision. So what's new in the diagnosis and progression monitoring? One is a tomographic-based classification system that recognizes all the anatomical layers. I hope I never go to another meeting and hear anyone utilize AMSLA-CRUMAC. It's a 70-year-old diagnostic system that really is useless nowadays. We have a tomographic-based progression display that documents when and if you get statistically significant change. How do I determine progression in very early disease? I utilize the progression display, which is the ABCD progression display. Any single parameter at the 95% confidence interval, or any 2 parameters at the 80%. For those of you who do your math quickly, 2 parameters at 80% roughly is the same at 1 parameter statistically at 95. Very important that all maps should be taken prior to any other procedures or drops. Thank you.